welcome. The BoreCore archive is a collection of slow, methodical recordings of technical processes and perfectly boring routines designed to help you relax and fall asleep. New procedures are added regularly, so don't forget to like and subscribe. Time to relax, close your eyes, and take it on down to Sleepy Town.
Welcome to a complete operational guide to the 11 to 7 night shift at a skilled nursing facility, including the shift handoff, rounds, medication administration, repositioning, incident response, documentation, and the particular quality of a long-term care unit at 3 in the morning when everyone is asleep, or what happens to the people in your care while you are not there, which is considerably more than you would guess. You are a licensed practical nurse working the 11 to 7 night shift at a skilled nursing facility. The facility is a 104-bed long-term care and post-acute rehabilitation center in a mid-sized city. It occupies a single-story building organized around 2 nursing units. The East Wing, which holds 56 residents in long-term care, many of whom have lived here for years and will live here until they die. And the West Wing, which holds 48 beds in the post-acute rehabilitation unit, serving residents who have recently had a hip replacement or a stroke or a cardiac event, and are working with physical and occupational therapists to regain enough function to return home. Tonight, both wings are nearly full. The East Wing has 53 residents, and the West Wing has 44. 97 people are in your care tonight. You are one of 4 nurses on this shift. The night shift at a nursing home is the shift that families rarely see, that administrators rarely walk, and that the residents experience in their most vulnerable state. The day shift has activity programs, family visitors, therapy appointments, physician rounds, and a general busyness that provides stimulation and social connection. The evening shift has dinner, television, the transition to pajamas, and the gradual quieting of the unit as residents go to bed. The night shift has the dark, and the quiet, and the work that continues after everyone else has gone to sleep. The work does not stop because the residents are asleep. In some respects, it becomes more important because the residents cannot speak for themselves and cannot call for help and cannot notice what is being done or not done on their behalf. The night shift is the shift that requires the most professional integrity because it operates entirely without witnesses. Your nursing background includes 12 years in long-term care, the last 7 at this facility. You know every resident on the East Wing by face, by name, by diagnosis, by the medications they take, by their sleep patterns, by which of them wakes at 2 in the morning wanting a cup of water, and which of them sleeps straight through until 5. You know the family members, and which ones call in the morning anxious for updates, and which ones have not visited in months. You know which residents are approaching the end of their lives, and which ones may be here for years more. You know these things not because you were told them at orientation, but because you have spent 7 years paying attention. Tonight's forecast is for a cold November rain beginning around 2 in the morning. The barometric pressure is dropping. You have learned over 7 years that a dropping barometric pressure corresponds with a higher rate of agitation and sleeplessness among residents with dementia. You cannot explain the mechanism. You have observed the correlation enough times to note it in your pre-shift preparation and adjust your expectations for tonight accordingly. Let us begin. You arrive at 10:45 in the evening, 15 minutes before your shift officially begins at 11. 15 minutes early is not a contractual obligation. It is a professional standard you have maintained since your first year in nursing, because a shift handoff conducted in haste produces gaps in information transfer, and gaps in information transfer at a nursing home produce events that harm residents. 15 minutes of unpaid time is a small price for a complete handoff. The evening charge nurse meets you at the nurse's station. The handoff is conducted in the hallway outside the station rather than inside it, because conducting a handoff in a closed room removes you from the visual field of the unit. While you are receiving information, you need to act on it immediately. The hallway handoff means you are simultaneously receiving the report and observing the unit. In 12 years, this practice has twice allowed you to see something in the hallway during a handoff that required immediate attention. On both occasions, the evening nurse would not have seen it if you had been inside the station. The evening nurse works through the SBAR format: situation, background, assessment, and recommendation. SBAR is a structured communication tool developed in the U.S. Navy and adapted for healthcare, designed to ensure that critical information is transferred efficiently and in a format the receiving clinician can act on. A handoff conducted as a narrative, in the order the evening nurse happens to remember things, is less reliable than a handoff conducted in a consistent structure that both parties recognize and can follow. Tonight's handoff has several items of note. In room 12 on the East Wing, Mr. Harold Delaney, 81 years old, admitted 3 years ago with Parkinson's disease and moderate vascular dementia, had a fall at 4:30 this afternoon. He was found on the floor beside his bed by the certified nursing assistant doing the afternoon rounds. He was assessed by the evening nurse, and the on-call physician was notified. No injury was detected on assessment. No obvious deformity. No reported pain on palpation. No change in mental status from baseline. An incident report was filed. However, the physician has ordered neuro checks every 2 hours overnight, which means you will be checking on Mr. Delaney's level of consciousness, pupil response, and orientation every 2 hours throughout your shift, documenting each check in the electronic health record. This is a significant addition to your overnight workload. In room 22, Mrs. Constance Ellery, 78 years old, end-stage congestive heart failure, is showing increased respiratory distress compared to her baseline. Her oxygen saturation this evening has been running at 90 to 92% on 3 liters of supplemental oxygen, compared to her recent baseline of 94 to 95% on the same flow rate. evening nurse has already notified the on-call physician, who has ordered a chest X-ray in the morning and instructed to notify immediately if her saturation drops below 88% on current oxygen settings, or if she reports increased shortness of breath. Mrs. Ellery is a DNR, do not resuscitate, and her goals of care conversation with her family has established comfort-focused care. She is not to be transferred to the hospital unless her condition worsens beyond what can be managed for comfort at the facility. 3 residents on the West Wing are scheduled for early morning medication administrations between 5 and 6 in the morning. A blood thinner for a resident who had a deep vein thrombosis, an antibiotic for a post-surgical infection, and a morning insulin dose for a diabetic resident whose endocrinologist has ordered fasting glucose checks before the dose. You note all 3 in your medication administration record. You also note that 1 resident on the West Wing, a 64-year-old post-hip replacement patient named Mr. James Ockefer, has been refusing his evening pain medications and insisting he needs to get out of bed and walk to the bathroom independently, which he has been instructed not to do without staff assistance while his hip heals. The evening CNA flagged him as a fall risk requiring monitoring and has placed a bed alarm sensor on his mattress. You note this. You sign the handoff form at 11:02. The evening nurse leaves. You are now the charge nurse for the East Wing, responsible for 53 residents. Your colleague on the West Wing, a registered nurse with 3 years at this facility, is responsible for the 44 residents on that side. 2 certified nursing assistants, CNAs, are assigned to each wing. You begin your shift. The first rounds of the night begin immediately after the handoff. The purpose of the first rounds is to establish a baseline, to see every resident with your own eyes, to confirm that the conditions described in the handoff are what you find in the room, and to identify anything that was not in the handoff. The evening nurse is thorough and professional. She may still have missed something. You look for yourself. The East Wing hallway is quiet. The overhead fluorescent lights are dimmed to their nighttime setting, approximately 30% of their daytime brightness, which provides enough light to move safely through the corridor without the full brightness that would disturb sleeping residents in rooms with open or partially open doors. The facility policy requires room doors to be open or partially open at night for visual monitoring. A completely closed door prevents a passing nurse or CNA from performing a visual check without entering, which creates delays in identifying residents in distress. Most residents have become accustomed to the partial open policy. A few prefer their doors closed, and the facility accommodates this preference by documenting it and requiring staff to open the door for visual checks. You begin in room 1 and work down the hall in sequence, which is the consistent route you use every night. Room 1. Mrs. Agnes Kowalski, 93 years old, dementia, sleeping quietly on her left side. Oxygen saturation monitor showing 96%. Respiratory respiratory rate appears regular. Room 2, Mr. Robert Chen, 88 years old, hip fracture resident transferred from rehabilitation last month when he plateaued in his therapy progress. Sleeping supine, bed rail up on the left side, as specified in his care plan, following a previous near fall. Room 3, Mrs. Dorothy Simmons, 81 years old, Parkinson's, has a position change scheduled for midnight, currently sleeping on her right side and slightly curled toward the edge of the mattress in the way she always is at this hour. You make a mental note. You reach room 12, Mr. Harold Delaney, the fall patient. He is in bed, awake. This is not unusual for him. He has a fragmented sleep pattern and frequently wakes in the late evening. He looks at you when you enter. You conduct your first neuro check. You ask him his name, which he gives correctly. You ask him where he is, which he answers correctly as the nursing home, though not by its full name, which is his baseline. You check his pupil response with your pen light, equal and reactive to light. You assess his limb strength by having him grip your fingers with each hand and push against your palms with each foot, which is symmetric and within normal limits. You ask about pain, which he rates at 2 out of 10 in his right hip, lower than it was this afternoon according to the evening nurse's note. You document the check in the electronic health record on the hallway workstation. The neuro check is normal and consistent with his post-fall assessment. You will repeat it at 1 in the morning. Room 22, Mrs. Constance Ellery. You enter quietly. She is semi-recumbent in her bed, head elevated approximately 45 degrees, which is the position she is most comfortable in and which minimizes her respiratory work. She is awake. She is often awake at night. You check the oxygen saturation monitor clipped to her finger, 91%. This is in the range the physician described, below her recent baseline, but above the notification threshold. You listen to her breathing without a stethoscope first. The pattern is labored, with a slight wheeze and the use of accessory muscles visible in her neck and upper chest. You ask her how she is feeling. She says tired. She says her chest feels heavy. You ask if she is in pain. She says no, not pain, just heavy. You make a note of her exact words in the chart. In a comfort-focused patient, the patient's own description of their experience is the primary clinical data. You will check on her again in 30 minutes. The rest of the first rounds take approximately 40 minutes. Of the 53 residents, 48 are asleep or drowsing. 3 are awake and watching television quietly in their rooms. 1 is awake and agitated, calling out at irregular intervals, which is her baseline, and which the CNA will manage with the redirection techniques documented in her behavioral care plan. 1 is sitting in her bedside chair, which she prefers to the bed for sleep, and which is documented in her care plan as an accepted preference. You note the status of each room in your shift log as you pass through. The first medication pass of the night begins at 11:45. Medication administration is the most high-stakes routine task in nursing, the task with the highest potential for harm if performed incorrectly. task whose safety culture has been most extensively studied and systematized in the history of modern nursing practice. The 5 rights of medication administration: right patient, right medication, right dose, right route, right time, are a mnemonic taught in every nursing program and repeated throughout every nurse's career. They are not repeated because they are complicated. They are repeated because the conditions of nursing work, particularly night shift nursing work with its fatigue and its quiet and its lack of external verification, create the exact conditions under which a competent professional will make an error if they allow routine to substitute for attention. The Medication Administration Record, the MAR, is the legal document that records every medication given to every resident and every medication withheld. At your facility, the MAR is electronic, maintained in the Pharmacy Integrated Electronic Health Record System. The system presents each resident's scheduled medications with their due times and allows you to document administration by scanning the resident's wristband barcode and the medication barcode, confirming a match before the medication is given. The barcode scanning system was introduced at this facility 4 years ago, and the rate of medication errors that reached residents dropped by approximately 60% in the year following implementation. The remaining errors are almost entirely associated with overriding the scanner alert, which nurses can do when barcodes are damaged or when a medication is not in the pharmacy's barcode system, and which is sometimes done improperly. You do not override the scanner unless you have a documented reason and have independently verified the medication by label reading. The 1145 medication pass serves 14 residents on the East Wing who have scheduled nighttime medications. The medications range from routine: a sleeping aid for a resident with chronic insomnia, a scheduled pain medication for a resident with advanced arthritis, an anticoagulant whose dosing schedule requires a late-night administration to maintain consistent blood levels, to more complex, an anti-seizure medication whose serum levels are sensitive to the timing of administration and which must be given within 30 minutes of its scheduled time. Each medication is pulled from the automated dispensing cabinet, which stores medications in individually locked pockets assigned to specific residents and specific medications, requiring your fingerprint and passcode to access. The cabinet records every withdrawal. You pull each medication, scan it, confirm it on the MAR, and prepare it for administration. The administration itself is the most deliberate part of the process. You enter each resident's room, wake them gently if they are asleep, and explain what you are giving them. Waking a resident to give a medication is not considered optional simply because they are sleeping. A medication that is administered to a sleeping, disoriented resident without verbal confirmation that they are swallowing is a medication that can be aspirated, inhaled into the lungs rather than swallowed into the stomach, causing aspiration pneumonia. Aspiration pneumonia is one of the leading causes of death in nursing home residents. You wake them. You explain. You wait for them to swallow and then offer water. For residents with dysphagia, a swallowing disorder that is extremely common among elderly patients with neurological conditions, medications require modification. A resident whose care plan specifies thickened liquids, a modification in which water and other thin liquids are thickened to a honey-like or nectar-like consistency to reduce the risk of aspiration, must also have their oral medications given with thickened liquid, unless the medication is available in a form that can be taken differently. Some medications can be crushed and mixed into a small amount of thickened pudding. Some cannot be crushed because the crushing destroys the extended release mechanism or the enteric coating. You know which medications on your medication pass can be crushed and which cannot. This is not information you look up each time. It is information you have carried for 12 years. The 11:45 pass takes approximately 55 minutes. You document each administration in the MAR as you go. 3 residents decline their sleeping aid, which is their right, and which you document as a refusal with their stated reason. 1 resident is unable to swallow his anti-seizure medication on the first attempt. You wait 5 minutes and try again with a different technique, placing the tablet further back on his tongue with a small amount of thickened water, and he swallows successfully on the second attempt. You document this. The medication pass ends at 12:40. You go to check on Mrs. Ellery. Between midnight and 2 in the morning, the CNAs perform the repositioning rounds. Repositioning is the regular turning and repositioning of residents who cannot reposition themselves, which includes residents with advanced dementia, residents who are bedbound following illness or injury, and residents whose mobility is sufficiently impaired that they cannot shift their own weight during sleep. The purpose of repositioning is the prevention of pressure injuries, which used to be called pressure sores or bed sores, and which are among the most painful, serious, and preventable complications of long-term bed rest. A pressure injury forms when sustained pressure on a bony prominence, such as the sacrum, heels, hips, or shoulder blades, compresses the soft tissue between the bone and the mattress surface, cutting off blood flow to that tissue. Without blood flow, the tissue begins to die. The progression from early redness to full-thickness tissue destruction can occur within hours in a resident who is malnourished, immobile, or circulatory compromised. A stage 4 pressure injury, which involves full-thickness skin loss, exposing muscle, bone, or tendon, is an extremely serious wound that can take months to heal, requires intensive wound care, causes significant pain, and dramatically increases infection risk, including life-threatening sepsis. The prevention of pressure injuries is not a comfort measure. It is a survival measure. The standard of care for pressure injury prevention is to reposition bed-bound or mobility-impaired residents at a minimum every 2 hours, alternating between positions that remove pressure from vulnerable areas. Supine, right lateral, left lateral, and in some cases prone if tolerated. The 2-hour interval is determined by the research showing that most tissues can tolerate up to 2 hours of sustained pressure without irreversible damage. Though in high-risk residents with compromised circulation or nutrition, 1-hour intervals may be indicated. Your facility's repositioning schedule is documented in each resident's care plan, along with their specific positioning needs, which positions they can tolerate, whether they have contractures that limit their range of motion, whether they require foam wedges or positioning aids to maintain a stable position, and which positions are contraindicated for clinical reasons. You supervise the midnight repositioning round and participate in it for the residents who require 2 nurse assistants for turning. Mrs. Agnes Kowalski in room 1, who is 93 years old and bedbound following a series of small strokes, is one of the 2 nurse turns. She weighs approximately 95 pounds, which is well below her admission weight of 112 pounds 18 months ago, and reflects the progressive weight loss common in late-stage dementia. The weight loss makes her easier to turn, but more vulnerable to pressure injury. The loss of subcutaneous fat removes the cushioning between the skin and the underlying bone, reducing the tissue's tolerance for pressure. You and the CNA position her from her left side to her right side, using the draw sheet under her as a turning aid, placing a pillow between her knees to prevent bony contact between them, ensuring her heels are floating free of the mattress surface by placing a pillow under her lower legs, and positioning her arm so it is not trapped beneath her body weight. You check her sacrum and left hip while she is off them. The sacrum shows a small area of persistent redness, approximately 1 centimeter in diameter, that blanches with finger pressure, which indicates stage 1 pressure injury, the earliest stage. You document this finding and note that it has been present since your last shift 3 nights ago, unchanged. You apply a moisture barrier cream to the area and note the application. The repositioning round for all bedbound residents in the East Wing takes approximately 5 minutes, with 2 CNAs working. During this time, you move from room to room, checking that each repositioning is performed correctly, conducting brief visual skin checks on the areas of highest risk, and documenting the incontinence care that is performed at each repositioning, cleaning residents who have been incontinent during the night, and applying barrier cream to protect the perineal skin, adds time to each room visit. Incontinence-associated dermatitis, the skin breakdown that results from prolonged contact with urine and stool, is the second most common cause of skin injury in long-term care after pressure injury, and the 2 conditions can compound each other. A resident with both incontinence and impaired mobility is at significantly higher risk for skin breakdown than a resident with either condition alone. You check the condition of the perineal skin at each repositioning. You apply barrier cream. You note any new skin changes in the chart. At 1 in the morning, you conduct Mr. Delaney's second neurocheck. He is asleep when you enter. You wake him gently by placing your hand on his forearm and calling his name at a normal speaking volume. He opens his eyes. He recognizes you, which is a meaningful clinical observation. A patient who becomes unable to recognize familiar faces after a fall may be showing the first signs of a developing intracranial bleed. Mr. Delaney has known you for 3 years. When you enter his room at night, he calls you by your first name before he is fully awake. He calls you by your first name now. You conduct the check. Name, location, year, grip strength in both hands. Plantar push against your palms with both feet, pupil response. All are at his established baseline. His pain, when you ask, is a 1 out of 10. He tells you his hip feels stiff. You adjust his pillow positioning slightly and offer him a glass of water, which he accepts. He is back asleep within 4 minutes of you entering the room. You document the second neuro check and note the time, 01:07. You return to room 22. Mrs. Ellery is awake. Her oxygen saturation is 90%. She is sitting up higher in the bed than she was at 11:30, which she does when her breathing becomes more difficult because the upright position reduces the work of breathing by allowing the diaphragm to descend more freely. You check her respiratory rate, 22 breaths per minute. Her resting respiratory rate at admission to the facility 8 months ago was 16 to 18. A respiratory rate of 22 in a patient with end-stage heart failure indicates increased cardiopulmonary work. Her skin is cool and slightly mottled at the knees and feet, a pattern called livedo reticularis, which indicates reduced peripheral circulation. You have seen this pattern before in patients with heart failure. You have seen what it sometimes precedes. You call the on-call physician at 1:15. The on-call physician tonight is a geriatrician who covers several long-term care facilities in the area on a rotating schedule, and who knows this facility and its patient population reasonably well. You present the SBAR, Mrs. Ellery's baseline, the change in oxygen saturation over the past 24 hours, the current saturation of 90% on 3 liters, the respiratory rate of 22, the modeling. The physician asks 2 questions. Has Mrs. Ellery expressed any wishes about her comfort tonight? And is her family aware of the change in status? You answer both. Mrs. Ellery has said she is tired and that her chest feels heavy and that she would like to sleep. Her family was notified by the evening nurse of the saturation change, and her daughter, who is her designated healthcare proxy, has been told to expect a call from the night shift if the situation worsens. The physician orders an increase in the oxygen flow rate to 4 liters and recommends a sublingual morphine dose for respiratory comfort if Mrs. Ellery agrees to it, which is a standard comfort measure in end-stage heart failure. You ask Mrs. Ellery if she would like the morphine. She says yes, You administer the sublingual morphine from the facility's controlled substance supply, drawing the dose from the automated dispensing cabinet using the double witness protocol required for all controlled substance withdrawals. The CNA on the floor serves as your second witness, confirming the dose drawn and the wasted portion, if any. You place the morphine dose under Mrs. Ellery's tongue. She closes her eyes. You stay with her for 10 minutes after administration, monitoring her respiratory rate and her comfort level. Her breathing slows slightly and becomes less labored. At 1:32, her oxygen saturation is 89%. You document everything: the assessment, the physician call, the order, the administration, the resident's response. You call Mrs. Ellery's daughter, calling a family member at 1:45 in the morning to tell them that their mother's condition has changed, is one of the aspects of night shift nursing that cannot be systematized and cannot be made comfortable by any amount of experience. You make these calls, and you have made them many times, and they do not become easy. What experience gives you is not comfort, but competence. You know what to say, how to say it, and how to answer the questions that will follow. Mrs. Ellery's daughter is named Patricia. She answers after 2 rings, which means she was probably not asleep, or was sleeping lightly in the way that people sleep when they are waiting for a call they know may come. You identify yourself and your facility. You tell her that her mother's condition has changed and that you wanted her to be aware. You describe the change. The oxygen saturation is lower than it has been. Her breathing is more labored. Her circulation to her extremities appears reduced. You tell her that you have spoken with the on-call physician and that a comfort medication has been given, which her mother agreed to, and which has helped her breathing somewhat. You tell her that her mother is not in pain. Patricia asks if she should come. This is the question that follows most of these calls, and it is the question you cannot answer for her. What you can tell her is what you observe: that her mother's condition tonight represents a change from recent weeks, that these changes in end-stage heart failure can stabilize and persist for some time, or can progress more quickly, and that there is no medical urgency requiring her presence at this moment, but that you would never tell her not to come if she wants to be with her mother. Patricia says she is 3 hours away. She says she will leave now. You tell her you will call her again if anything changes before she arrives. You give her the direct number to the nurse's station. After you hang up, you sit for a moment at the nurse's station. This is not a pause born of distress, or not only that. It is the pause of a professional who has just had a conversation that required their full attention, and who is now returning their attention to the unit, which requires a transition. The unit does not pause for the call. There are 97 residents in this building tonight. 53 are your direct responsibility. The call is documented. The medication is documented. Mrs. Ellery is as comfortable as she can be made. You return to the floor. You check on Mrs. Ellery at 2 in the morning. Her daughter will not arrive until approximately 4:45. Mrs. Ellery's oxygen saturation is 88%. Her breathing is slower than it was at 1:15, which is partly the effect of the morphine and partly the natural progression of her illness. She appears to be sleeping. When you say her name quietly, her eyes open briefly, and she appears to recognize you, then close again. You stay in the room for 5 minutes. The rain has started outside. You can hear it on the window. At 2 in the morning, the resident in room 17 begins calling out. This is not unexpected. You noted when you were reviewing the barometric pressure earlier that the dropping pressure often corresponds with increased nighttime agitation in residents with dementia. And the resident in room 17, Mrs. Alina Banks, 86 years old, moderate to severe Alzheimer's disease, is one of the residents whose behavior is most weather sensitive on this unit. Nighttime behavioral disturbances in dementia, sometimes collectively called sundowning, are among the most challenging aspects of long-term dementia care. The term sundowning refers to the phenomenon of increased confusion, agitation, wandering, or vocalizations in the late afternoon and evening and nighttime hours. And while the exact mechanism is not fully understood, it is believed to involve disruption of the circadian rhythm, which the progressive neurological damage of Alzheimer's disease impairs along with memory and executive function. A resident with intact circadian function knows, on a biological level, that it is night and that sleeping is appropriate. A resident with disrupted circadian function may experience the nighttime as confusing or frightening, may not understand where they are or why they are in a bed in a strange room, and may respond to that confusion with the behaviors that are most natural to them when frightened: calling out, attempting to get up, becoming agitated. The management of nighttime agitation in dementia requires a specific approach that is different from the approach to behavioral disturbances in other contexts. The first principle is non-pharmacological intervention before pharmacological. The research on sedating medications for nighttime agitation in dementia is mixed at best and concerning at worst. Many of the medications historically used for this purpose, including benzodiazepines and certain antipsychotics, carry significant risks in elderly patients, including increased fall risk, respiratory depression, and, paradoxically, increased confusion. The Centers for Medicare and Medicaid Services has established regulatory requirements limiting the use of antipsychotic medications in nursing home residents to cases where they are clinically necessary for specific diagnoses, and your facility has a strong culture of non-pharmacological behavior management. You go to Mrs. Banks. Mrs. Banks is sitting up in bed when you enter, calling out in a repetitive pattern that is not words, but vocalization, a sound of distress. You approach her calmly, at the same level as her rather than standing over her, which reduces the physical intimidation that a tall figure appearing in a dark room might produce for a confused person. You speak in a quiet, even tone. You tell her your name. You tell her she is at the nursing home. You tell her she is safe. You take her hand if she permits it, which she does tonight. The physical contact of a warm hand is one of the most reliable comfort interventions for agitated residents with dementia, because it is sensory and immediate in a way that verbal reassurance cannot be when language comprehension is impaired. Mrs. Banks' care plan specifies several non-pharmacological interventions for nighttime agitation that have been identified through trial and observation over her 2 years at the facility. A warm blanket applied to her shoulders, a small glass of warm milk if she will accept it, a soft radio playing classical music at low volume, and a familiar photograph on her bedside table, positioned where she can see it from the bed. The photograph is of her daughter and son-in-law at a family event, taken approximately 15 years ago when Mrs. Banks could still recognize them. She may not recognize the faces in the photograph now, but the image is familiar, which is different from recognizable, and the familiarity appears to have a calming effect. You apply the warm blanket. You offer the milk, which she accepts. You turn on the radio to the classical station. You reposition the photograph. Mrs. Banks' vocalizations decrease within approximately 8 minutes of these interventions. By 2:10, she is lying back in her bed, eyes open but quiet, the radio playing softly. You remain in the doorway for another 5 minutes, visible but not intrusive, available if she becomes distressed again. She does not. At 2:20, she appears to be sleeping. You document the episode, onset time, nature of behavior, interventions implemented, response to intervention, duration. The documentation is not bureaucratic. It is clinical data that will be used by the morning team, by the social worker who manages Mrs. Banks, behavior care plan, by the family when they visit, and by the physician at the next clinical review. At 2:30, the bed alarm in room 41 on the west wing activates. This is Mr. James Ockheffer, the 64-year-old post-hip replacement patient who has been refusing assistance and attempting to ambulate independently. The bed alarm sensor detects when a resident whose weight has been removed from the mattress, indicating they have gotten up or are in the process of getting up. The alarm sounds at the central nurse's station and at a small repeater in the hallway near the room. The West Wing nurse and the CNA nearest the room both respond. You are notified by radio because the West Wing covers for East Wing when their nurse is occupied, and Mr. Ockheffer's fall risk requires immediate response. Falls in a nursing home are among the most serious adverse events the facility must manage. They are not rare. Approximately 1 in 3 nursing home residents falls at least once per year, and the consequences of a fall in an elderly person with multiple comorbidities can be catastrophic. A hip fracture in a nursing home resident over the age of 80 carries a 1-year mortality rate of approximately 20 to 30%. A subdural hematoma from a head strike in a resident on anticoagulation therapy can be fatal within hours. Falls are the most litigated adverse event in long-term care. They are also, to a significant degree, preventable, which is why fall prevention is one of the most intensive focus areas in nursing home quality management. Fall prevention is not a single intervention. It is a multidimensional program that includes environmental modifications, resident-specific interventions, medication management, and staff behavior. Environmental modifications include bed alarms like the one that just activated, non-skid footwear, adequate lighting in hallways and bathrooms, removal of loose rugs and tripping hazards, and equipment such as grab bars and raised toilet seats. Resident-specific interventions are documented in the Fall Risk Care Plan and include things like call light placement within reach, hourly rounding by staff to offer toileting assistance, and the specific restrictions on independent ambulation that Mr. Ackefer is currently subject to following his hip replacement. The West Wing nurse arrives at Mr. Ackefer's room in approximately 45 seconds from the alarm activation. He is sitting on the edge of the bed, feet on the floor, not yet standing. He is not in pain, and he is not on the floor. This is the best possible outcome for a bed alarm activation. The alarm worked as intended. The staff responded before a fall occurred, and the resident is safe. He is, however, frustrated. He tells the nurse he needs to use the bathroom, and he did not want to wake anyone at 2:30 in the morning. The nurse assists him to the bathroom with the walker, confirms he is stable, waits outside the bathroom door, and assists him back to bed. After Mr. Ackefer is back in bed, you speak with the West Wing nurse briefly in the hallway. The pattern of Mr. Ackefer's behavior, attempting to ambulate independently because he does not want to bother the staff at night, is a pattern you have seen many times in post-acute residents who have been independent adults their entire lives and find the loss of independence in a rehabilitation setting psychologically difficult. The clinical solution is not to add more restrictions, but to reduce his perceived barrier to asking for help. The CNA on his wing will begin proactive hourly rounding to offer him toileting assistance so that he does not reach a point of urgency where he feels he has no option but to try to go himself. You note the plan in the West Wing communication log and add it to the morning report for the day charge nurse. The night shift's observation of this pattern at 2:30 in the morning is what drives the care plan adjustment that prevents a fall tomorrow night. At 3 in the morning, the unit has settled back into its nighttime quiet. Mrs. Banks is sleeping. Mr. Delaney passed his 1 o'clock neuro check. Mrs. Ellery is resting, her daughter on her way. Mr. Ackefer is in bed with the proactive rounding plan in place. You sit at the nurse's station and work through the documentation that has accumulated during the active hours of the shift. Documentation in nursing is not a clerical task performed in addition to nursing care. It is a clinical and legal obligation that is integral to nursing care, because the care you have provided is not professionally complete until it has been documented in a format that allows the next clinician to know what happened and to build on it. A nurse who provides excellent clinical care and documents it poorly has not fulfilled the standard of practice. The resident's health record is the continuum of their care, maintained by every clinician who touches them, and each clinician's contribution to that record is the mechanism by which the care is continuous across shifts, across disciplines, and across providers. The electronic health record at your facility integrates the nursing assessment forms, the medication administration record, the care plans, the physician orders, the therapy notes, and the administrative documentation into a single system. The integration is imperfect in some areas. Some fields require redundant data entry. Some nursing notes are not easily visible to the therapy team, and the physician orders interface is occasionally unintuitive. These are the practical realities of electronic health records in long-term care, which has historically received less investment in health information technology than acute care hospitals, and whose regulatory documentation requirements are extensive and facility-specific. You navigate the system efficiently because you have been using it for 4 years and have memorized the workflows for the documentation tasks you perform every night. You complete the narrative nursing note for the shift so far. A narrative note is a brief written summary of the clinically significant events of the shift, written in a standardized format that includes the observation, the assessment, the intervention, and the response. The note for Mrs. Ellery's change in condition takes approximately 12 minutes to write. It covers the saturation trend, the physician notification and response, the comfort medication administration, the family call, and the current status. It is written in the language of nursing documentation, objective, specific, free of editorializing, focused on the clinically relevant. A note that says resident appears to be declining is not a nursing note. A note that says resident's O2 saturation decreased from 91% at 23:30 to 88% at 200 hours on 4 liters per nasal cannula. Respiratory rate 22. Increased accessory muscle use noted. Sublingual morphine 0.5 milligrams administered per physician order at 01:30, with moderate improvement in respiratory comfort per resident report, is a nursing note. You also complete the required 2-hour documentation for Mr. Delaney's neuro checks, ensuring each check has a time-stamped entry with all assessed parameters. The 2-hour check documentation will be reviewed in the morning by the day charge nurse and potentially by the facility's director of nursing, and it creates the legal record that the physician's order was followed. If Mr. Delaney were to develop a subdural hematoma in the hours following his fall, this documentation would establish that he was monitored appropriately at the required intervals, and that the neurological changes, if any, were detected and reported promptly. The documentation work at 3 in the morning has a particular quality. The unit is quiet. The hallway light is dim. The residents are mostly sleeping. You are at a workstation that faces the hallway, which means you can see the corridor while you type. You are simultaneously documenting the events of the past several hours and watching for anything new. This is what night shift nursing looks like from the outside at 3 in the morning. A nurse at a computer, alone in a quiet hallway, typing. From the inside, it is the careful maintenance of the medical and legal record that protects the residents, the facility, and the nurse herself, conducted at the pace that the quiet hours allow, which is the same pace as everything else on the night shift. Not hurried, not casual, but steady. From 3:30 to 5 in the morning is the deepest part of the night shift, the hours when the body's circadian pressure towards sleep is strongest, and when the unit is at its quietest. The second repositioning round occurs at 2 in the morning and the third at 4, bookending this window. In between, the work is monitoring and presence, checking on residents who need closer attention, being available for call light activations, and maintaining the vigilance that the night shift requires even in its quietest hours. The call light system is the mechanism by which residents communicate with staff from their rooms. Every room has a call light button at the bedside and in the bathroom, and activating it illuminates a light above the door and signals the nurse's station. In most nursing homes, there is also a pull cord in the bathroom that residents can use if they fall or need assistance. The call light response time is monitored as a quality indicator at your facility. The standard is a response within 5 minutes, with an acknowledgement of the call within 2 minutes. A call light that goes unanswered for 10 minutes at 2 in the morning is a call light that may represent a resident in distress who has been waiting for 10 minutes. It may also represent a resident who wanted a glass of water. The nature of the call cannot be known until someone answers it. Between 3:30 and 5 this morning, you respond to 4 call lights. The first is from a resident in room 9 who cannot find the television remote, which has fallen between the bed rail and the mattress. You retrieve it. The second is from a resident in room 31 who is having pain rated at 6 out of 10 in her lower back, which is a chronic condition for which she has a scheduled pain medication at 5:30, but which has become acute enough tonight that she is asking for the as-needed dose that is also in her medication orders. You assess her, confirm that the pain is consistent with her chronic condition and not a new acute presentation, and administer the as-needed dose. You document the assessment and administration. The third call light is from a resident in room 8 who is confused about where he is and who is asking for his wife. His wife died 7 years ago, and he was told and understood and has forgotten. You tell him his wife is not here tonight, but that he is safe and that you are here. He appears to accept this. You adjust his pillow and he lies back down. The fourth call light is a bathroom call. A resident who is ambulatory with a walker needed assistance to the bathroom and back. You assist her. She thanks you. The 4 call lights in 90 minutes is a moderate night. Some nights produce 10 call lights between 3 and 5. Some nights produce 1. The variability is a function of individual resident needs, the overall health of the census, and the factors you cannot control, including the weather, which continues to rain outside. You are not surprised by the 4 calls. You are prepared for more. At 4 a.m, you check on Mrs. Ellery before the 3rd repositioning round begins. She is sleeping, or appears to be. Her oxygen saturation is 87%. You check her respiratory pattern. It is slow, with longer intervals between breaths than 2 hours ago. A pattern called Cheyne-Stokes respiration, which involves a cycling between deeper and shallower breaths, and is associated with changes in the brain's control of breathing that can occur in advanced heart failure and in the hours preceding death. You note the time and the observation. You call the on-call physician briefly to report. The physician notes the observation, concurs that this is consistent with the natural progression of her illness, and confirms the comfort-focused care plan. No additional orders are needed. You call Patricia, Mrs. Ellery's daughter, and tell her that her mother appears comfortable and that her breathing pattern has changed. You tell her the facility address again. She says she is about 40 minutes away. At 4:52 a.m, you check on Mrs. Constance Ellery and find that she has died. You have been in this room many times tonight. You have been a nurse for 12 years. You have been present for deaths before, and you have found residents who died in the night before, and neither of those facts makes this a routine moment. What they give you is the capacity to act, to do what needs to be done in the correct order, with the attention it deserves. You take a breath. You begin. You confirm the absence of respirations and pulse. You note the time, 4:52. You do not attempt resuscitation. Mrs. Ellery had a valid do not resuscitate order, documented in the electronic health record, and in the paper DNR form in the front of her chart, and her goals of care plan explicitly specified that resuscitation was not consistent with her wishes. Her death has occurred in the manner and the setting that she and her family had discussed and agreed upon. In her bed, in her facility, on comfort medications, without a hospital transfer, without the machinery of acute resuscitation that she had specifically said she did not want. You observe a moment of stillness. Then you call the on-call physician. The pronouncement of death in a nursing home requires a physician, or in many states, a licensed nurse practitioner or physician assistant, to physically or remotely confirm the death and issue a pronouncement. The on-call physician, when you call at 4:56, takes the report, asks the confirmatory questions required by the state's long-term care regulations, and pronounces Mrs. Ellery deceased at 4:52, the time you noted. He tells you he is sorry. You tell him you will handle the notifications. You hang up. The notifications after a death in a nursing home follow a specific sequence established by the facility's policy and by the state's regulations. The family, the funeral home designated by the family, the facility administrator, or the administrator on call, and the state health department if the death requires reporting, which deaths in long-term care facilities do in most states. The family call comes first, always. Risha is approximately 15 minutes away. You call her. She answers immediately. You tell her that her mother died at 4:52 this morning. You tell her that she appeared to be sleeping and that she was comfortable. You tell her that you were with her earlier in the night and that she had told you she was tired and that her chest felt heavy and that after the medication her breathing became easier. You tell her that you are sorry for her loss. Patricia cries. You stay on the phone. You do not fill the silence. Some silences are not meant to be filled. Patricia says she is almost there. She asks if she can still come. You tell her yes, of course, that she is welcome to come and sit with her mother, that there is no rush. She arrives at 5:14. You meet her at the front door and walk with her to room 22. You stay in the hallway outside while she goes in and closes the door. You will give her as much time as she needs. The funeral home has been called and is aware of the situation and will not be dispatched until Patricia has had whatever time she needs. The facility administrator has been notified. The regulatory notifications have been filed electronically. The documentation of the death, the time, the circumstances, the notifications made, the care provided in the final hours will be completed after Patricia leaves. For now, you are available in the hallway if she needs you, which is where you should be. At 5:30, Patricia comes out of room 22. She has been with her mother for approximately 15 minutes. She is composed in the way that people are composed when they have been preparing themselves for something, and the thing has finally happened. She thanks you. She says her mother spoke well of you and of the facility. You tell her that her mother was a pleasure to care for, which is both a true statement and a professional statement, and both of those things can be true simultaneously. You walk her through the next steps. The funeral home will come to the facility, typically within 1 to 2 hours of being called, and will transport Mrs. Ellery's body. Patricia will need to contact the funeral home directly to confirm the arrangements. The facility will provide a death summary to the physician and to the family. Mrs. Ellery's personal belongings will be inventoried and can be collected by the family at their convenience. If Patricia has any questions about the care her mother received, she can speak with the director of nursing during business hours. Patricia nods through all of this. She squeezes your hand at the door and goes to her car in the parking lot. The rain has stopped. The sky is beginning to lighten in the east. Return to the nurse's station and complete the death documentation. The death note in the electronic health record takes approximately 20 minutes to write completely. The clinical events of the night, the timeline of the saturation changes, and physician notifications, and comfort medication administrations, the time of death and the pronouncement, the family notification call, the regulatory filings. The note is written in the same language as every other nursing note: objective, specific, complete. It is the record of what happened and what was done and how. And it will be reviewed by the State Health Department as part of the facility's quality reporting. And it will be available to Patricia if she ever has questions about her mother's final hours. And it will remain in the medical record as the permanent account of Mrs. Constance Ellery's death. At 4:52 in the morning on a rainy November night, in the place she called home for 8 months. Mr. Delaney's 3 o'clock neuro check was normal. His 5 o'clock check, conducted by the CNA who is proactive rounding the East Wing, will be your last required check before the morning shift arrives. You conduct it at 5:45. Name, location, grip strength, pupils, pain, all at his baseline. He asks you if it is morning yet. You tell him almost. He says good. He says he is hungry. You tell him breakfast begins at 7:30. He says that is too far away. You tell him you will see what you can do about a cup of tea and a piece of toast. He says that would be something. You go to the small kitchen adjacent to the nurse's station and make tea. At 5:45, while the tea is steeping, you begin the early morning medication pass. The 3 residents who require early medications before the day shift are the focus of this pass: the blood thinner, the antibiotic, and the insulin with the fasting glucose check. You pull each medication from the automated dispensing cabinet, verify each one, and prepare the equipment for the glucose check. The fasting glucose check for the diabetic resident, Mr. Thomas Brennan on the West Wing, requires a finger stick blood sample taken from the fingertip using a lancet and a blood glucose meter. Mr. Brennan is a 68-year-old post-cardiac event patient who has been in the facility for 3 weeks following a heart attack and is working with the cardiac rehabilitation therapy team. His diabetes has been difficult to manage in the acute post-cardiac period because his dietary intake has been variable, and his stress response physiology has elevated his insulin resistance. The endocrinologist has ordered finger stick glucose monitoring before the morning insulin dose because she does not want insulin administered if his glucose is below a specified threshold, which would risk hypoglycemia. You wake Mr. Brennan at 5:55. He is cooperative and accustomed to the morning glucose check. You perform the finger stick on the lateral aspect of his right ring finger, which is one of the sites recommended for finger stick glucose testing because it is less sensitive than the fingertip pads and has adequate capillary blood flow. His glucose reads 142 milligrams per deciliter. The endocrinologist's order specifies to administer the morning insulin dose if glucose is greater than 120 and less than 250, and to call for guidance if outside this range. At 142, the dose proceeds. You administer the subcutaneous insulin injection into the adipose tissue of his abdomen, rotating the injection site from the location documented in the chart from the previous morning. Rotating injection sites prevents lipohypertrophy, the accumulation of fibrous tissue at repeatedly injected sites that impairs insulin absorption. You document the glucose value, the insulin dose and site, and the time. The antibiotic and the anticoagulant are administered to their respective residents without incident. Both residents are awake and cooperative for their early medications. You complete the early pass, document all administrations, and return to the East Wing to bring Mr. Delaney his tea. Mr. Delaney accepts the tea with both hands and holds the cup close to his face, which he does in the mornings when the unit is cold. You sit in the chair beside his bed for approximately 5 minutes while he drinks, which is longer than clinical necessity requires, and shorter than it would be if you had fewer things to do. He tells you about his granddaughter, who sent him a photograph last week of her new apartment in Denver. He says the apartment looks very small. You say that apartments in Denver are expensive. He says everything is expensive. You agree. He finishes the tea and you take the cup. His neuro check at this morning visit is normal. You tell him you will see him Thursday when you are back on. He says to bring more tea on Thursday. You tell him you will do your best. The day shift begins arriving at 6:30 for the 7 o'clock shift start. The day charge nurse for the East Wing, a registered nurse with 15 years at this facility, and a clinical knowledge of the resident population that matches your own, arrives at 6:45. You begin the handoff at 6:47. The handoff is conducted in the same SBAR format as the handoff you received last night, because the format works, and because the day charge nurse received the same communication training you did and expects the same structure. You begin with the most significant item. Mrs. Constance Ellery passed away at 4:52 this morning. The day charge nurse knows Mrs. Ellery and has cared for her for the 8 months of her residence. She receives this news in the way that experienced long-term care nurses receive the deaths of residents they have cared for, with a moment of acknowledgement, then a return to the task of the handoff, because there are still 52 living residents on this wing who need a competent handoff between nurses. The grief is real. It does not interrupt the work. You work through the remainder of the handoff systematically. Mr. Delaney's fall and the neuro checks. All 7 completed and normal. Last check at 5:45. No neurological changes. Pain down from this afternoon's 4 out of 10 to a 1 this morning. He has been eating and drinking and asking for breakfast. Mrs. Banks' nighttime agitation episode at 2 in the morning. Onset, duration, interventions, response, all documented in the chart. The classical music intervention was effective as it has been before. The bed alarm activation for Mr. Ackefer on the West Wing at 2:30. No fall, proactive rounding plan initiated, documented in the West Wing log for the day shift there. The early morning medications completed for all 3 residents. Glucose, insulin dose, sites, all charted. You also brief the day charge nurse on 2 residents whose conditions you want to flag for their attention today, beyond what is in the documentation. A resident in room 6 whose skin showed increased fragility at last night's repositioning, with a small skin tear at the left elbow that you dressed and documented. But that warrants a wound care assessment by the wound care nurse today, and a resident in room 29 whose urine output from the overnight incontinence care appeared darker and more concentrated than usual, which may indicate inadequate fluid intake and warrants monitoring of oral intake and a possible hydration assessment by the physician. The handoff is complete at 7:03. You sign the handoff form. The day charge nurse takes over the east wing. You gather your personal items from the break room, clock out at 7:08, and walk to the parking lot. The morning sky is clear after the overnight rain. The air is cold and smells of wet leaves. Your car is one of the last ones in the lot at this hour, a holdover from when the overnight staff parked and the lot was empty. You sit in the car for a moment before starting it. This is also a transition. The shift is complete. The residents are in other hands. You drive home. The night shift you have just completed took place within a regulatory and ethical framework that shapes every aspect of long-term care practice in the United States. And understanding that framework helps explain many of the specific practices described in this script. Skilled nursing facilities in the United States are regulated primarily by the Centers for Medicare and Medicaid Services, CMS, under the authority of the Omnibus Budget Reconciliation Act of 1987, commonly called OBRA 87. OBRA 87 established the Resident Bill of Rights, a foundational document in long-term care that specifies the rights of nursing home residents, including the right to be informed about their care and treatment, the right to participate in care planning, the right to privacy, the right to be treated with dignity and respect, the right to make their own choices about daily life, and the right to be free from abuse, neglect, and misappropriation of property. The Resident Bill of Rights is not a set of aspirational principles. It is a legal standard enforced through the federal survey and certification process, and violations of resident rights are among the most serious deficiencies that a surveyor can cite during a facility inspection. OBRA 87 also established the requirement for comprehensive resident assessments using a standardized tool called the Minimum Data Set, MDS, which captures detailed information about each resident's functional status, cognitive status, mood, behavior, medical diagnoses, and care needs. The MDS is completed at admission, at prescribed intervals during the resident's stay, and following any significant change in condition. It is the clinical foundation for the care plan, which is the individualized document specifying the care goals and interventions for each resident. The care plan is a living document, updated at each quarterly and annual care conference, and whenever the resident's condition changes significantly. Every intervention you performed tonight, the repositioning schedule, the non-pharmacological dementia interventions for Mrs. Banks, the fall prevention measures for Mr. Acaffer, the comfort-focused care for Mrs. Ellery, was specified in each resident's care plan. The staffing ratio during your night shift, 1 nurse for approximately 53 residents, is at the lower end of what research suggests is adequate for quality care, but is not atypical for night shifts in American long-term care facilities. Staffing in nursing homes is a persistent and serious policy issue. The ratio affects the ability of nurses to provide timely, attentive care to each resident, and inadequate staffing is one of the most commonly cited factors in nursing home quality failures. The CMS implemented a staffing minimum rule in 2024 that requires nursing homes to provide a minimum of 0.47 hours of registered nurse time per resident per day and 0.17 hours of registered nurse time on each shift, plus a total nurse staffing minimum, including licensed practical nurses and certified nursing assistants. The regulatory and industry debate about appropriate staffing levels is ongoing and reflects genuine tension between the cost of staffing at higher ratios and the quality and safety benefits those ratios produce. The ethical framework of long-term care practice centers on resident autonomy, dignity, and the recognition that a nursing home is not merely a clinical setting, but a home. The residents of a skilled nursing facility are not patients in the conventional acute care sense. Many of them have lived in the facility for years and will live there until they die. Their wishes, preferences, and values must be honored within the clinical constraints of their care, and the care plan is the mechanism by which their preferences are documented and implemented. Mr. Delaney's preference for tea in the early morning is in his care plan. Mrs. Banks' preferred music and her response to warm blankets are in her care plan. Mrs. Ellery's goals of care wishes, developed in conversation with her family and her physician and her social worker, were in her care plan and were honored completely tonight. The documentation that sometimes feels bureaucratic is the infrastructure through which a person's preferences persist across the shifts and staff who care for them, none of whom can individually know and remember everything about every resident. The care plan is institutional memory in service of individual humanity. You have completed an 11 to 7 night shift at a skilled nursing facility. During this shift, you received and documented a complete shift handoff, conducted first rounds of the entire East Wing, confirming the status of 53 residents, administered the 1145 medication, pass to 14 residents, supervised and participated in 3 repositioning rounds, conducted 6 two-hour neuro checks on a post-fall resident, identified and managed a saturation change in a comfort-focused end-of-life resident, administered comfort medications and coordinated physician orders, called the family of a dying resident, and provided information and support across multiple calls, managed a nighttime agitation episode in a resident with dementia using non-pharmacological interventions, responded to a bed alarm activation, and coordinated a care plan change to address the underlying behavior pattern, completed documentation throughout the shift, including a detailed death note, performed the early morning medication pass including insulin administration with a fingerstick glucose check, made tea for a resident who was hungry before breakfast, and delivered a complete SBAR handoff to the incoming day shift. You did all of this for 97 people who were asleep, or trying to sleep, or dying, or frightened in the dark, and who needed you to be competent and present and steady, which you were. Long-term care nursing is among the least recognized and least compensated specialties in nursing, which is a statement about professional culture and compensation structures rather than about the difficulty or the importance of the work. The clinical complexity of caring for a population that is elderly, multiply comorbid, cognitively impaired, and often at or near the end of their lives is substantial. The emotional complexity of caring for people across years, knowing them and their families and their preferences and their histories, and then being present for their deaths, is also substantial. The night shift amplifies both complexities by removing the ambient social support of the daytime environment and leaving the nurse alone with the work and the responsibility. Mrs. Ellery died as she had wanted to die, in her facility, on comfort care, with medication to ease her breathing, with her daughter on her way. She was not alone in her last hours. You checked on her at 10:45 when you arrived, and at midnight, and at 1, and at 2, and at 4, and the last time you saw her alive, she appeared to be sleeping and appeared to be comfortable. This is what good care looks like at the end of life, not the absence of dying, which cannot be prevented, but the presence of someone who knows what to watch for and who watches, and who acts when acting is needed, and who sits with the family in the hallway when sitting is what is needed, and who writes down what happened so that the record is complete. You were present. You watched. You acted. You sat. You wrote it down. Mrs. Banks is sleeping. Mr. Delaney is waiting for breakfast. Mr. Acaffer will have his hip checked by his surgeon next week, and if the progress report is good, he will begin walking to the bathroom independently before the end of the month. The resident in room 9 will find the television remote in the same place next week and the week after. The resident in room 8 will ask about his wife again. There will be more nights like this one, and different nights, and the unit will continue, and the residents will continue, and the work will continue, which is what work does and what good work requires. People who show up for it. Thursday's shift begins at 11. Mr. Delaney wants tea. The barometric pressure should be stable by then. The rain is finished. The day shift has it from here. You drive home. You sleep. Good night